it's only 3 days a month, but 3 days out of a month for the rest of your life is 10% of your life. There are many different causes now being theorized for endometriosis.
That makes it even more complicated, right? Because you would never think of having endometriosis just because you have constipation.
In third world countries or something, I've had patients from California, from Stanford, who've had their imaging done there. So the most important thing is to listen.
Welcome to the Wellness Mixer. I'm Ambika, and like many of you, I had a lot of questions about stuff that affects my hormones, my health. Am I PMSing? Is PMS even real? Is this diet going to fix my PCOS? What is PCOS? And should I take OCPs for my PCOS? Can you fix PCOS? All of these questions have given us sleepless nights. But on this show, I uncomplicate all of this for you. In this episode, we're going to talk about a condition that affects 1 out of 7 women globally. This condition not only affects women physically, but also is mentally taxing. It's overlooked, underdiagnosed, and misdiagnosed, to say the least. Endometriosis. And to discuss more on this, we have Dr. Mangeshikar with us today. He's one of the leading specialists for endometriosis around the globe. He's an endometriosis surgeon at Gislok Hospital and leads a team there. He's a consultant at Breach Candy Hospital, and we have him here today. And he's also known as Dr. Mangs. Very interesting because he's been doing a lot of great work to spread more awareness about endometriosis. Hi, Dr. Abhishek. Welcome to the Wellness Mixer.
Hi, Ambika. Thank you for having me in Bangalore while I'm visiting. It was well thought out and well planned, and I'm glad to be here.
I'm so glad you agreed for this. And by the way, the one reason I wanted to have him here is because I'm scared of doctors. I'm scared of my own doctor too, but he's very nice, but I'm scared of him. It's just been a thing. And I know a lot of women are, I don't know if they're scared, but there's a very complicated relationship with doctors, right? Because it's a very common phenomena. You enter the clinic and it's your turn. You're going to talk to your doctor and then you forget what questions you had in mind, right?
Yes. I made a post about that. So I encourage patients to write down their questions. So you don't have that moment where you blank out and then when you leave, you remember, I should have asked him that.
Yeah. Even I take notes because otherwise it used to be like, okay, uncle, I had migraine, I had this, I didn't get my period. And then when he'll be writing the prescription and making his notes, I'll be like, one more thing, this also happened. So yeah, it's best to take notes. That's good advice. Before we dive into endometriosis, let's talk about period pain. Okay, now period pain has been normalized by a lot of doctors and specialists, and I think in our society, right? We've been told that it's just 5 days a month. You can deal with it and get on with your life. But is that so? Is period pain even normal?
That's a very good place to start because it lays a foundation for what this is going to be about. So I tell patients and when I give lectures, I say that any pain that is affecting your quality of life is affecting your decision making, whether you can play sports, go to school, go to work, or enjoy social activities or intimacy, is not normal. There is a lot of gaslighting to young women in their adolescence and as they get older, that period pain is normal. But pain is a very subjective thing. So yes, you might have mild cramps, which can show up for one day, which is not necessarily endometriosis, but somebody with the disease may experience very severe debilitating pain where they start to question what's wrong with their bodies because they're being told by society, familial and medical peers and mentors that this is normal and it's part of being a woman and grow up. And gynecologists also are guilty of this because they are told things like, once you get older, it'll be fine. Once you get married and have babies, it'll be fine. And once you go through menopause, it'll be fine. So it's really just dangling this carrot all the way to the end of their lifespan.
Does it ever get fine is the question then.
No, of course, pain is important, and it's very important to listen to somebody's pain because it's not psychosomatic necessarily that it's being imagined just because imaging can't find it. It is... A pain is a very important symptom because it's self-preservative, right? So if you touch a frying pan that's very hot, your instinct is to take your hand away because your brain is telling you that's hot, you're getting nerve damage on your fingers, so take it away. And that's why you feel pain. So pain that somebody may experience in the pelvis or in the abdomen is indicative that there is something wrong there, and that's the signal that is coming from the brain that, figure out what's wrong and fix it.
I think a lot of women, at least I was told to have menstrual spas and use Mangeshikar and a lot of these medicines because I used to have, I think the first 2 days used to be bad for me and then it would get better during the third or fourth day and I was just told to have menstrual spas. How normal is that or is that okay?
So to circle back to what you said, you're told... Not you specifically, but
yeah, women in general.
Young ladies are told, it's only 3 days a month, but 3 days out of a month for the rest of your life is 10% of your life.
Yeah.
3 out of 30. So that's obviously not normal. So, and that's why when Americans are very good at statistics, so they looked at the losses that are incurred because of endometriosis. So they saw a huge reduction in earnings, in career potential, in academic growth with these patients. There was in 2019, there was a really good study by the BBC for almost close to 20,000 patients with identified endometriosis. And out of them, there was, a lot of them reported chronic absenteeism, unable to go to work, unable to go to school. A lot of them had suicide ideation at some point in their lives because of pain, and a very small percentage, but a significant percentage actually attempted it at some point. So it's not right for anyone to belittle someone who's in pain until you can actually identify what they're going through, or even empathize with it on a level, and kind of as a medical specialist, we have to kind of help them to figure out what is the cause of the pain.
Definitely. I think let's start with what is endometriosis. What are some of the symptoms, and also let's discuss what are some of the hidden symptoms.
Okay, so basic definition is endometriosis is defined as endometrial-like tissue, so tissue that resembles the lining of the uterus or the womb outside the uterus and outside the pelvis as well. So it is not that the period blood is flowing backwards as the original theory of retrograde menstruation was. Almost all women have retrograde menstruation of some form, and the ectopic endometrium is not really the autotransplant disease that we once believed it to be. There are many different causes now being theorized for endometriosis, including that it may be laid down during the formation of an embryo along different cell lines, and how it manifests can occur at the onset. So you have genetic traits, you have epigenetic factors that determine how the disease grows, where it grows, how aggressive it is, and why some people may have it and why some people may not, even though they may have the genes. So that is what endometriosis is, but the symptoms are very interesting because there are so many of them and they mimic so many other conditions. And unfortunately, a lot of symptomatology in OBGY practice in India and globally focuses more on the fertility aspect of it rather than the pain. And interestingly enough, I think only about 30% of women with endometriosis suffer from fertility issues, whereas about 90 to 95% have some form of pain. But there is a inertia in the medical practice to not treat endometriosis unless someone is desirous of fertility. This came piggybacking off one of the consensus statements that said a surgery for endometriosis should be one and done. So you shouldn't have multiple surgeries for endometriosis. Now, what the actual intent behind this was that the surgery should be done by someone who knows what they're doing, who is able to remove all the disease and to do it well so that the recurrence rates are dramatically lower. The problem was that everybody thinks they can do endometriosis surgery. So they delay treatments as far as possible, telling them to get pregnant, pushing them towards pregnancy. And then rather than treat the disease, they push them into IVF cycles, which we now have evidence showing that in the presence of disease, the IVF cycles are more likely to fail than those without disease. And then eventually this patient is going through years of pain and years of infertility now induced because of the progression of disease. And that eventually may end up with a hysterectomy, which is still not a solution because, like we've said, by definition, this is disease that exists outside the uterus. So
it can grow anywhere.
It can grow anywhere. Why would you consider removing another organ to fix a problem in somewhere else? So I always use the example, like if you have appendicitis and you go to a gynecologist and he tells you, okay, I'm going to remove your uterus. Does it sound logical? So why would it sound logical for, say you have disease in the rectum, you have disease along the nerves, you have disease in the diaphragm of the chest. Removing the uterus or inducing surgical menopause by removing the ovaries is not an answer to fix that. You have to treat the disease where it is. There is no other specialty where treating another organ is going to work as a treatment for the actual pathology itself. So it's unfathomable to think that it's going to work in gynecology.
That leaves me thinking, then there is no definite solution to endometriosis as of now?
I don't think that's necessarily true. Because it's got this tag as a very difficult disease to treat. So if we estimated the global load of endometriosis in our population, it's 200 million or something like that. And from what they estimated, there are only about 200 or 300 specialists in the world who can remove the disease. So that's like a drop in the ocean. And out of those 300, there are about 50 who can do very advanced disease, which is even if all of those 50 people, or rather even all of those 300 people work nonstop for the rest of their lives, they're not going to make a dent on the global impact of the disease. So, but what we can do is work on each patient and do the job properly. So the recurrence rates, when they looked at general OBGYN, were 50 to 80% after surgeries. But this is because most people get very fixated on the cysts or the endometriomas. But an endometrioma never exists by itself. There's always the accompanying deeper disease or peritoneal disease, which is a film that lines the entire abdomen and pelvis. So it can grow anywhere along that layer of tissue. Now, the ability to remove that and identify that is what reduces the recurrence rate. So when they zoomed in that camera on the centers of excellence for endometriosis and they looked at their recurrence rates, so those recurrence rates dropped down to single digits and not the 50 to 80%. So I would argue that the 50 to 80% statistic is more persistence of disease rather than disease that is coming back. It's not coming back if you are not removing it in the first place. It's just there.
So there's a root cause and you didn't need to remove that.
Yeah, you have to remove the disease in its entirety from the roots.
Yeah.
That's how it'll work.
So for our audience, let's just explain endometriosis in very layman terms, okay? So a lot of our audience may not be familiar with the term endometrial lining, right? It's the lining, my understanding it's the lining that we shed every month when we bleed during our period, right? Now, this lining starts growing outside of the uterus?
No. So That's what was considered earlier. But it is tissue that is similar to this lining, but it's not the same thing. So they share similar characteristics under a microscope, but they have many other differences in terms of that. So the tissue itself can grow literally anywhere in the body. And what it does is it undergoes response to hormones.
Okay.
So estrogen and progesterone, it's sensitive to both, but most cases are more estrogen sensitive. And they undergo inflammation, which causes the surrounding blood vessels to burst, so the lesions themselves don't bleed, but they cause inflammation that cause the blood vessels around them to rupture. And when there's bleeding, there's scar tissue that forms. So that's fibrotic part of the disease. And those form little nodules. Now, this is going on repetitively every month. So it's a continuous cycle of tissue injury and repair. And that's where you get inflammatory nodules surrounded by fibrotic scar tissue.
And that's what's causing the pain too.
So if scar tissue, like if you've seen a scar, it pulls everything towards it. So it pulls vessels, nerves, organs towards each other. So normally if you consider the three compartments of the pelvis, which is the anterior compartment is the bladder, the middle compartment is the uterus and the ovaries on either side, and the posterior compartment is the rectum and the pelvic side walls. These compartments should be able to move independently over each other. In endometriosis, advanced diseases, you have compartments that get stuck together because of this, because there's disease between two compartments and that causes them to get fused together. So it's like somebody has thrown a hand grenade into the pelvis and everything has gotten stuck together.
Oh, that sounds very painful. Is pain, like period pain, one of the first few symptoms of endometriosis, or women who sometimes don't experience this pain can also have endometriosis?
Yeah, that's a very good question. So it's not just, it's much more than a painful period. They can experience pain prior to the onset, during, and even after the period. And in some cases, they can have chronic pain as well. So 30 days out of the month, they're in pain. 15 days out of the month, they're in pain. It varies. So we don't just focus on symptoms during or around menstruation. We ask for an overall symptom of pain. In a usual pattern, this is not for everyone, but you would see a flare-up of symptoms just at the onset of the period, because that's when the estrogen levels are highest. So in those cases where the estrogen sensitivity is higher, there is a flare-up of endometriosis, which is normally reported in patient symptoms. Now, apart from pain during the periods, there's pain associated with bowel movements. You can have pain while passing stools. You can have constipation. You can have alternating constipation and diarrhea. You can have severe bloating, where it can, what's called the endobelly, where they can look a couple of months pregnant, and it's very painful to wear, a belt or jeans or something like that. So they have to wear sweatpants or a dress, and that can be very painful and uncomfortable for them. You also have symptoms of painful intercourse, where it's either at the vaginal opening or deep down in the pelvis at the back of the vagina if there is a nodule associated there. So these usually are telltale signs. If you have pain radiating down the leg, you probably have it on the pelvic side wall or along the nerves. So a lot of sciatic pain can be from endometriosis if the patient has a history of other symptoms. So we don't, brush it off and say, go see an orthopedic surgeon, because they're never going to find it. And so we have to look at all of these symptoms, and we look at chest symptoms. There can be shoulder pain, pain under the ribs. There can be, sometimes coughing up blood. Some extreme cases have lung collapses, where they end up in the emergency room every month because their lungs collapse and they don't know why. So it's very important as a specialist to spend time and ask all these questions, because the patient may not consider it a gynecological symptom. So we have to screen and kind of come to a working diagnosis. So also one of the things I do is neuropelvology, which is a study of the nerves of the pelvis, which is a very interesting branch in medicine, where you understand that nerves supply different parts of the body. So if you have radiating pain down the leg, for example, and you have bladder symptoms, If the patient has overactive bladder or something like that, and she has difficulty voiding, then I can, without even examining, I know that there is a lesion along particular sacral nerve roots. And obviously, once we do the MRI or the ultrasound, we get a confirmation of that diagnosis. But neuropelviology is important, where you understand to listen to the patient. That's the most important thing. And then you can come to a roadmap to have a working diagnosis of what you're going to find.
You know what's strange? A lot of these symptoms can be so easily overlooked, like constipation. Nobody can think of this, right? Like, if you think of constipation and you go to your doctor, ideally in India, I don't think people go to their doctor for constipation either. They'll just be like, okay, I'll make slight changes to my diet, eat a banana. Because every time I'm constipated, my mother will be like, eat a banana, have isabgol. Like, this is the usual advice everyone gets in the house, right? You would never go to a doctor for constipation until and unless it's extreme and chronic in nature. And that just makes me think that, this can be so easily overlooked. And even if you go to the doctor's not going to say get a screening for endometriosis just because you have constipation. So how do you approach this subject with your doctor? And even if someone, by the way, period irregularity is not a symptom of endometriosis, or is that?
No, that's more PCOS related.
That's more. So that makes it even more complicated, right? Because you would never think of having endometriosis just because you have constipation.
Yeah. Like I said, a lot of patients with endometriosis in the bowel, so that's the intestine. The rectum usually is the most common site, and then you have it higher up on the large intestine, and sometimes in the appendix and the small intestine as well. But constipation, when accompanied with pain, is a very big red flag for endometriosis. And a lot of these patients are misdiagnosed as IBS, and they come in saying, I have IBS. And I said, no, you don't have IBS, because IBS is a diagnosis of exclusion, which means you've ruled out any pathology that is causing the symptoms. And when you have endometriosis in the bowel, that is not IBS, that is bowel endometriosis. And once you remove the disease, the symptoms are usually gone. And IBS can, of course, coexist with endometriosis. We're not saying that it doesn't exist. But in most cases, a lot of patients have been mislabeled as IBS and just been dealt that hand, and they said they have to deal with it, when in reality they don't have to deal with it.
And I've heard a lot of cases of IBS recently, to be honest. I'd not heard of IBS maybe 5 years ago, but in the last 5 years, I've like 2 of my flatmates had it, and then I know somebody else who had it, and they're all like taking probiotics and gut health supplements. But is there a chance that a lot of women have been mislabeled with IBS in India?
Absolutely. Not only in India, globally. Like, I've had patients, the fortune I have is that I'm in Bombay and it's easily accessible, and I treat patients from pretty much all over the world. So even if you consider this is not a misdiagnosis in third world countries or something, I've had patients from California, from Stanford, who've had their imaging done there, where they have come back with a report showing normal in the rectum, and there was a huge mass sitting in the rectum itself. And they just missed it. So it's not an India-centric problem, it's a global problem, because a lot of the disease is being missed even by imaging specialists, and a lot of gynecologists don't do their own imaging. So they tend to just read the report that's handed to them, which is going to lead to a lot of problems. Slowly, there's a move towards improving the imaging protocols for endometriosis, so we tend to miss less disease, but that's a change that will happen and improve over time.
That's my next question. What are the tests or imaging that you should get done, or your doctor should ideally recommend you to get done?
So the most important thing is to listen. That's the best diagnosis. You cannot be a general OBGYN and, sitting with a patient for 5 minutes and then, moving on to the next patient. Endometriosis consult takes a minimum of 40 minutes to an hour.
Oh, okay.
So we spend about 15 to 20 minutes talking about symptoms, And then I'm trying to kind of understand a mental map of where I'm going to be looking for certain things. Then, of course, you have examination of the areas. And I also do my own ultrasound when I see a patient for the first time, which is a transvaginal ultrasound if she's sexually active. An abdominal ultrasound is not useful at all for us.
Oh,
So we
okay.
never do that. And if the patient is not sexually active, then I just refer her to get an MRI.
Okay.
And usually, because this reporting is never standardized, for me to look at the imaging myself is more important. So I say, I don't care where you get the MRI done, just get the imaging from them. And so I can look at it myself. Which is why I also insist on doing my own ultrasound, because you can't trust somebody else's ultrasound report if they're not looking in the right places.
Yeah. So I think what happens is when you go to your gynac, they'll ask you to get an ultrasound, and then you go to a third party testing center, get your ultrasound, and they write the report. Like if if it's a polycystic ovary, then they will write that, and weight of volume of the ovaries and all of that, right? So you don't look at that. You do the imaging yourself.
So I'll tell you why this is. So what happens is you go to a regular gynecologist, they say, okay, you have pain, go get an ultrasound and come back. Now the ultrasound tech is going to do a quick ultrasound where they just look at the uterus and the ovaries. What you need to do for endometriosis is look at everything, all the three compartments we spoke about earlier. We have to check whether they're moving over each other. We have to check along the length of the bowel to look for nodules in the rectum or higher. And they don't do any of these things. We look for tenderness. We look to see whether the ovaries are stuck or whether they're moving, and all of those things. So there's a specific protocol for endometriosis ultrasound,
Okay.
not just reporting about the uterus and the ovaries and leaving it there. So even if they have a cyst, now the patient will go back to the doctor with an ultrasound report saying, you have a cyst in the ovary. Now this doctor has not thought that there is deeper disease or it is there. So they schedule them to remove a cyst, which they will go and do. Now, the cyst is the easiest part to treat of the endometriosis, so it takes about 20 minutes to do. To remove the disease underneath the deep disease or the peritoneal disease can take sometimes up to an hour, sometimes up to 4 hours, depending on how severe the disease is.
Okay.
So the cyst is usually just a marker for deeper disease. It's not the whole and soul thing. So a lot of patients, I've already had endometriosis surgery. I've had a cyst removed. That's really not the answer.
The key is to remove the disease
Yeah.
from its roots, basically.
All the three subtypes. So you have ovarian cysts, which are endometriomas or chocolate cysts. You have peritoneal disease, and you have deep disease, which are the big nodules that can grow anywhere in the body.
Okay. And you mentioned all the testing, right? Because there are going to be protocols about this. How many testing centers in India actually follow these protocols?
Like maybe 3 or 4 in the whole
What?
country. So there are a few radiologists who update themselves, or they work with some endometriosis surgeons, and they've kind of told them, like, look, this is what I'm looking for. And this. So when I started out, nobody was doing it. I had to learn how to do the imaging myself. And then obviously in Just Look, we had a very good team, and they're very open and communicative. So I used to go down to the department and say, like, look, this is what I found in surgery. Go back and look. And that's how we learn from each other.
Okay.
Sometimes they would come and see what they found and, review the video to see if they missed anything and go back and forth. So then we developed protocols to determine how much disease there is and what we're going to do for endometriosis mapping. Globally now, there are some staging systems coming about that can be used for imaging that will kind of standardize that reporting. But again, the ability to diagnose is very operator dependent. On a sidebar, I'm also working with an AI company to train machines to pick up disease.
I was just going to say, with generative AI now, does that make your job easier to detect it?
So we don't have any products available yet. They're all in testing phase, and eventually it will happen. The more the machine is exposed to data, the more accurate it will become. There are already preliminary scientific papers showing that they're good sensitivity and specificity, which is what you look for when you're standardizing diagnosis. So I think AI is definitely the future. I don't think it's going to replace doctors, but it's definitely going to help make our jobs a lot easier.
Absolutely. I think that's what AI is doing. I don't think it's going to replace humans, but it's definitely going to make our job easier in all of the fields.